Hello and welcome to webinar series. Myself Shanti, and today's topic is all about MR LINAC in cancer care. As we all know, this technology is a very massive technology and the world's best and India's first quantum leap technology. And it is just like the cutting device, adapted with the MRI and radiation therapy in cancer care. Yes. For this discussion now, I welcome our esteemed expert, none other, Dr. Sai Subramanian Garu, who is our Chief Medical Physicist for Group Yashoda Hospitals. I welcome you, Dr. Sai.
Thank you. Thank you. It's a great pleasure being here.
Yes, and so do we are privileged to have you with us today. Yes. Now I would like to invite our speakers to introduce themselves. Yes, over to you, Lipika.
Hello, very good afternoon to one and all. I'm Miss Lipika. I'm from Tripura, working as an SSZ professor in Tripura Institute of Paramedical Sciences. And once again, it's a pleasure for me to be in a part of this webinar and hoping for it will be a very good session.
Yeah, we do. I think, Sunita, are you there?
Yes, ma'am.
Yeah, over to you.
I'm Sunita Veerabatni. I'm working as a Deputy Nursing Superintendent, Renova Century Hospital, Banjara Hills. I'm more pleasure to be involved in this webinar. Let's see, it's a very innovative technology which can be treat cancer patients with. I wanted to hear from the sir. Thank you, ma'am.
So, let us learn because this is really a great booming technology in treatment of cancer. Yes, because as we know, the drastic rise of cancer in among the Indian population. Yes. Now, over to you, Dr. Sai, for your very productive insight on how would you describe about this MR LINAC technology in very short, time. Yes. Over to you.
Thank you. Thank you for being having me here. Because it's a general audience, I would just take a little few minutes to talk about little on the cancer. Because if you look at the cancer cell, it will have its nuclear at one place and its tail at finite distance. That's why whenever you have a surgery done for a cancer, they undergo a little larger margin. They cut through a little longer distance and then remove the cavity because it's always have its root at one place. That's one of the main reasons where you have the scrab as given as a symbol for cancer. So, when you do when the cancer occurs in a very important areas or very eloquent areas, the problem is that like when you do a surgery, you have to cut through the nearby tissues. When you cut through the nearby tissues, you are going to lose the functionality of that particular structure. There is a problem because if you have it in the cheek, if you're going to cut through that, you have seen many times head and neck patients having a very distorted face because you cut through that area, you lose your mandible, and then patient had a lot of quality of life deteriorated. This is the where the radiotherapy comes in picture. Where radiotherapy, we give the very high energy X-rays, which will be delivered to the tumor, plus the areas close to that, preserving the particular structure. But to preserve the particular structure, you have to have a proper dose delivered, at the same time reduce dose to the other structures nearby, because we should not hit that structures with the high energy X-rays. Otherwise, it will create problem to the patient. But to perform this, we need to have a proper technology to do that. We have a linear accelerator which is responsible to deliver the high energy X-rays. But the problem we always had faced is that like how to diagnose or how to map that area where the tumor is there. That is where the imaging system comes in the picture. People traditionally use for so many years CT scan as a modality, and they do CT scan, draw the tumor in the CT scan, and deliver the treatment. But cancer is never is always a soft tissue tumor. When it is a soft tissue tumor, we all know that the MRI is a golden standard. With the MRI, we'll be able to see the tumor much better, plus the boundaries of the tumor with respect to the particular structure. If you have an MRI and a linear accelerator together, that is fantastic because you are able to see the image properly, see the tumor properly, see the critical structures properly, and then you can deliver the structure, deliver the dose. That can be a game changer in the sense because you are able to see it well, so you can deliver dose better. So the better you see, the better you deliver the dose. The better you deliver the dose, that can translate to lesser side effects, at the same time better survival. There comes the advantage of this particular machine, where we use high energy X-rays along with the MRI images to see the cancer cells and deliver the dose.
Yes. Going forward, we will also be discussing about, all these features of MR LINAC. Yes, we, have Lipika, who is from Tripura.
Yes,
Yes,
ma'am.
Lipika, over to you for your,
Uh,
what is your query which you want to clear with,
yes,
Dr.
ma'am.
Sai. Yes, over to you.
Yes, sir. Hello, sir. As in the recent years, we have seen that the cancer is one of the growing concern, regardless of any geographical boundaries, age, gender, races, etc. So, how we can this particular procedure, ML LINAC, is distinct from the other procedures, and what is the mechanism? How does it work on the this cancer treatment therapy? If you enlighten us a little bit more about this.
Yes, it's a very, very valuable question, because in the sense, like, as the number of patients are growing now with this technology, previously we used to do cancer radiotherapy treatment 20 days, 40 days. But now
Mm,
there are some sites where liver, lung,
mm,
prostate, and rectum, these sites
mm,
we can treat the patient in 5 days. So the treatment, which is 20 days or 40 days treatment, get reduced to 5 days. And now we are working with the Royal Marsden Cancer Hospital in London, where we
mm,
can do a trial for 2 fraction treatment. In the sense, like, a patient with a prostate tumor can be cured in 2 days of radiotherapy. That is wonderful, because this machine, because we are able to see the image tumor properly, and also MRI has the capability to do a real-time position during the treatment. We have never ever seen a tumor when the radiotherapy has been delivered. But now with MRI, we can see the real-time tumor. Because we are able to see the real-time imaging, we are able to deliver the dose, very high dose, which we do it in
mm,
20 days, can be done in
mm.
2 to 5 days without having more of, even lesser than side effects than what we do with the 20 days treatment. That is definitely a game changer, right?
It means it's a
Yes.
super precise treatment therapy.
Absolutely right. Because you have an MRI, which is the golden
Mm,
standard for cancer imaging, whereas you have a linear accelerator, which is ideal for the radiotherapy treatment. If you combine
yes.
these two, you will be able to deliver a much better dose. And the possibility of reducing the number of fractions to 5 fractions and 2 fraction treatment makes life easy.
Mm,
Like, how you go for a surgery, even surgery nowadays, you have 3 days, 4 days post-surgical. Uh, you have to be there
yes.
in the ward, observation, and all those things. But whereas with
Yes.
radiotherapy, patient walks in, walks out. So from the house, they come here and get treatment for 20 minutes and then go back. And then next day they come for treatment 20 minutes and then go back. And then we are done.
So you mean to say that these tumors are movable in nature, like
Yes.
as you were mentioning, right?
Absolutely
Like,
right. Absolutely
yes.
right. Because when we treat a liver patients or a lung patients, they do with the respiration. The liver and lung moves craniocordally more than 2 to 3 centimeters. So if you are
Yes.
not having a proper technology to image the tumor, you will be treating the entire lung and liver with the
Mm,
radiotherapy. That is why sometimes patients land up with radiotherapy side effects after treatment. But with this technology, we can track the tumor because we can do a live MRI imaging during treatment. That is real beautiful thing which we have never ever done for the last 30 days,
Yes. Yes.
30 years.
Yes, and just for the audience, on behalf of audience, I would like to have this, insight from your end as well. Like, what kind of radiation does it emit? Like ionizing, but or
Okay.
the like it was mentioned like 1.5 Tesla, and
Yeah.
whether it is a electron or photon. Yes, so what do
It's
you say?
it's a 6 million volt X-ray photon beams. So these
Okay.
photon beams interact with the patient's atoms, body atoms. So as they interact with the patient atomic level, they don't generate molecular vibration. Anything which hits a molecular level only generates heat. So that is why whenever we treat the patient in radiotherapy, they won't feel heat, they won't feel any no pain at all, because they won't have any sensation, because the system interacts with the atomic level. When it interacts with the atomic level, no vibrations of molecules, so no heat production, no sense of objects coming in the picture. So patient will
Yes.
not feel anything when you do radiotherapy. And it
Yes.
uses 6 MB X-ray, so it can penetrate deep into the body and deliver the dose.
Yes. So if you look at this imaging, like patient is on the table and this couch or the table bed, which moves a 360-degree
Yeah.
for
The
its a
Gandhi,
real accuracy. That
yes.
you mean to say, Dr. Sai?
Yes, absolutely.
Yes.
Absolutely. Because if there is a tumor at one location,
Yes.
we don't put from only one direction all the beams. We put from
Yes.
all the 360 degrees. So the system rotates at 6 revolutions per minute and deliver the dose. So that's why the treatment time is so fast, because it's quite fast in delivering the dose.
Yeah. So you mean to say the gantry,
Gantry
gantry
rotates around the
moves.
patient.
Yes,
The
yes, yes,
couch stays and the gantry rotates around the
yes,
patient.
yes. Yes.
I,
Let us also hear from Sunita. Sunita, over to you for your discussion. Yeah.
ma'am, I do have one more doubt, sir. I just wanted to get the clarity while doing a procedure, the treatment. If any situation arises like a critical situation, if the patient want nausea sensation, wanted to vomit, so in that scenario, how we will manage the scenario?
Can we stop?
We have
Yes.
Yes, I think we have all the precautions set in, but even, of course, anything can happen in between actually. So these technologies are designed in such a manner that even if you stop the treatment in between, we can restart the treatment without any problem where we stop. Because you are doing all the treatment with the image-based techniques. The moment you have an image-based technique, once the patient has some issues, we have a direct connection between, and we monitor the patient continuously during the treatment in terms of anatomical as well as physical. So there are cameras for the physical changes of the patient, plus patient can communicate with the buzzer through us that if he feel uncomfortable. So three-way we monitor. Internal anatomy is monitored by real-time MRI imaging. So your heart is monitored with MRI, your tumor is monitored with the real-time imaging, and the cameras are there to see physically patient is moving or not. Plus, third thing is that like the buzzer is there directly, which patient can communicate directly to that, and we can listen what patient is talking also. So with this, we can really interact. In case of any kind of untoward incidents, we can immediately go inside and do the job.
Yes, very interesting.
Fantastic.
And yes, and one more. I think, Sunita, I'll just take this, your time. Like, yeah, does MR LINAC run with AI for its real precision-based imaging, Dr. Sai?
Yes, of course. Now everything runs in the AI, the way it goes in
Yes.
with this world. But MR LINAC also no more excluded from that, because in MR LINAC, every day when patient comes, the patient anatomy
Mm.
changes because internal organ movements, tumor movements, everything. So we do MRI, but the problem is that every day you have to map. But how do you spend time mapping? Because patient on the couch, if you start mapping for half an hour, patient will move. So what you do is that like the system is so clever that previous day's mapping, it takes and use AI and adjusts the anatomy according to that, so that the mapping becomes 95% perfect. And then manually we do 5% corrections and then treat the patient. So without AI, definitely it is very difficult to do a real-time treatment. And that to this much high dose with such a short time, we need AI to do that.
So you mean to say let's say if at all this, a case comes with the initial, detection of lung cancer, you mean to say
Yes.
the patient or whatever the irrespective of age, the patient has to just take this 20 minutes of radiotherapy, which is
Yes.
nothing but adaptive ones, and then go home, and frequently the periodic cycle has been designed or prescribed by you, and then the problem gets cured. Is that
Yes, of
you
course.
mean?
Lung patients, we really do a 5-fraction treatment, very high
Okay.
dose of 5-fraction, because traditionally we do 60 gray in 30 fractions, which we deliver in 5 days. But the advantage is that like because we are doing a everyday marking, because every day the tumor moves in a different direction.
Yes,
So you
yes.
mark that, in that AI comes in the picture, because AI will help us in how it is moving on that particular day. Then we can adjust the system and tell the system that today's movement is this way, so we have to deliver the dose this way. Like quite challenging,
Very
but
nice.
very interesting.
Yes. Yes, Sunita, over to you again. You
So
get back.
what kind of cancers can be treated? As we know, the
Yes.
majority cancers, like, so you are telling it's a external beam therapy type. So what do you, how do you manage in case of bone cancer and blood cancers?
Or does
Yes.
it,
Both.
give the radiation for pediatric cancer, pediatric group as well?
Yes,
Yes.
almost all 95% of the cancers can be treated, but there are some exclusions. Like in the sense, like suppose you have a blood cancer. Blood cancer has to be treated for the entire body. So we don't do in MR LINAC. We do in a conventional linear accelerator, because
Yes.
conventional linear accelerator is enough, because you don't need a MRI imaging to target the tumor, because blood is everywhere, right? So you have to you have to make the patient to stand and deliver the full dose to the patient. So in that case, we do in a conventional linear accelerator, blood and all. But bone
Yes.
cancer, if it is only one particular area of the bone, then we can try with the MR LINAC. Otherwise, we go with the conventional LINAC. Other than that, most of the cancers can be very well treated with the hair, right from the brain, head and neck, thorax, pelvis, abdomen. prostate, cervix, everything is very well covered. And in fact, it has shown survival benefit in pancreas treatments. If you treat the patient in a conventional LINAC with the pancreas tumors, and if you treat with the same pancreatic patient with the MR LINAC, patients, the survival benefit is almost comes close to 3 years extra. So that's quite a lot. That can really make a lot of difference for the life. Prostate patients, if you treat in a conventional LINAC and if you treat with the MR LINAC, the genitourinary urinary toxicity is reduced by 25%. Because if you look at prostate cancers, most of the patients are old patients. They already are 60 plus. They already have a urinary incontinence and other problems. Any treatment should not deteriorate their quality of life. In that context, if you look at MR LINAC can really deliver a very high dose and reduce the toxicity. Their quality of life, we have done 70 patients of prostate, and we could see that 69 patients has absolutely no complaint, except one patient which you already had a problem with the surgical. Otherwise, it was so good because we are able to give such a precise tumor to the prostate without delivering any dose to the bladder rectum. So this is really a magic bullet.
Sir, as you already
Yes.
mentioned regarding that lung can be movable organ, the same like the cancer organs like a bladder, it's a liquid consist. So
Yes.
can we able to visualize clearly what tumor size and all?
Yes, nice question. I think it is much clearly visible because with the MRI, T2 imaging can be done so well, and then we can differentiate. And what we do is that, like, we make the patient to have a finite hazard of glasses. We control the bladder filling and then deliver the treatment. And we do real-time monitoring of the bladder filling and then deliver the dose so that we don't cross the tolerance limits of the bladder, at the same time deliver the dose to the bladder tumors.
Very interesting,
And
sir.
we could really see the tumor response during the treatment also. It's a shrinkage of the tumor. So that's really wonderful to see that, because when the treatment is going on, is the patient is responding or patient is not responding. It's really fantastic to see that. This machine gives the idea for us, because this machine has a diffusion weighted imaging, in the sense like this system has the capability to see inside the tumor how the tumor is tightly packed. If the tumor is tightly packed or tumor is loosely packed. If the tumor is tightly packed, we give little higher dosage because the tumor has more cells in it, so it may recur. So what we do, we try to do a diffusion weighted imaging, find out the tightly packed area and deliver a little higher dose, and find out the areas where if it is loosely packed, then deliver the normal dose to the patient.
Yes.
So we call it as biological guided radiotherapy.
That's very wonderful to hear to that, sir. So I have one more little queries about this. As you have mentioned, in most of the cancer, kind of cancer, it can be treated. What about the stages of cancer? Means, is there any specificity that in that particular stage means it cannot be treated or something like that?
As such, there is no restriction on that. But only thing is that now what we are doing is that, like, there are two ways, like stage 1 and stage 2 is curable. So in that case, we deliver in a different way. Stage 3 and stage 4, what we do is that, like, it's not as curable from the radiotherapy point of view, but it can really play a role if you combine with the immunotherapy.
Okay.
So what we do is that, like, we take the junk of the palliative disease, we deliver very high dose to a confined small area. Rest of the areas are taken by the immunotherapy treatments. So it's like combining 2-3 modalities to get the best benefit for the patients.
Yes. Okay. What do you again, Lipika? Before I
Yes.
would like to interrupt you. Like, yes, Dr. Sai, can the therapy can be just given alongside chemo as well?
Yes,
Case of
absolutely. Head and neck cases, head and neck cancers, we always give along with the particular day where the chemo is given, the same day evening we do that, because chemotherapy acts as a radiosensitizer. So when you have a chemotherapy in the body and then if you give radiation, it adds more to the tumor and kills more number of tumor cell deaths. So that's definitely a good idea to have some patients to have a chemo together with radiotherapy.
Yes. Listening to your discussion is really like we are just getting to understand the beacon of hope for cancer patients. Yes. Now, over to you, Lipika, for your further
Yes,
coin
ma'am.
with Dr. Sai. Yes.
Yes. Another thing is that how this particular treatment, MR LINAC, it is different from our very traditional or this method, traditional treatment like radiation therapy. And means what is the prognostic value? As earlier also you have mentioned regarding the precise dose delivery, this one.
Yes,
So can you a little bit elaborate or explain us more regarding the precise dose delivery in terms of
okay,
this therapy?
perfect. It's a
Yes.
nice one, nice question. In a traditional, what we do is that like when a patient is referred for radiotherapy, we take the patient to a CT
Yes.
scan. We make suppose we take a head and neck patient. So a patient
Yes.
having a head and neck tumor, what we do, we make a mask and we take the patient to CT scan, do a CT scan.
Yeah.
Then the CT scan, we draw the tumor and then we put the beams, we plan the beam, we make everything is fine. The tumor dose is perfect and the critical structures are fine. And then we deliver the treatment, assuming
Yes.
that the first day what we planned is being delivered for the third day, 30 days. But nothing happens like that. You people know very well, a head and neck patient, cancer patient loses weight a lot. Like
Yes.
so,
Yes.
during the treatment of radiotherapy of 30 days, they lose a lot of weight. When they lose weight, the body shrinks. The changes are not happening, but we don't adapt at all. We just treat with the same
True.
plan. That is absolutely wrong, right? So that's like
Yes.
in
Yes.
your nursing terms, like if the patient weight is this much, you give this much amount of drug.
Yes.
Mm.
The moment
Yes.
patient
Yes.
loses the weight, you change the drug, right? The dose.
Yes.
But we don't do that in
Yes.
traditional treatments. But now in MR LINAC, the advantage is that like every day you do MRI and you find out if there is a reduction in the body, you change your beams, you change your dose. So that way, the
Okay.
advantage is that like the patient getting a side effect. Like, when you do a head and neck patient, the patient having a parotid glands land up with the xerostomia. So dryness of mouth,
Mm.
most of the head and neck patient land. But with
Yes.
this MR LINAC, we can really avoid that. Patient will have a difficulty in swallowing, dysphagia. That can be really avoided because you can
Yes.
do everyday contour the dysphagia structures and pharyngeal constrictor and reduce dose to that area so that patient will be able to tolerate radiotherapy so well.
So
Yes.
you mean to say patient do not lose weight with this adaptive technology of MR
Yes.
LINAC?
Yes,
Yes.
one
Yes.
way is right because what we do is that like we try to reduce the margin. In a conventional linac, we don't do everyday imaging because here we are doing everyday imaging. We don't give more margins to the tumor. We keep it very tight so that the normal tissue coming in the field is coming less. So in that case, patient will be able to swallow. If the patient is able to swallow, he will eat well. If he eats well, then the body will not lose weight.
Yes. So
Yes.
yeah, we are just nearing to the end of the discussion. Yes, over to you, Sunita, as we are going to keep the session very time bound. Yes, over to you.
Sir, I have a question that during entire procedure, the patients can be experience any kind of pain or any difficulties?
Pain will not be there, as I said very clearly in the beginning.
Yes.
The beam will interact with your atomic level. Anything which is interacting with the atomic level will not create any vibration. So as it will not create vibration, it will not create any heat. As it does not create any heat, your body pain nerves will not sense that.
Mm.
So patient will not feel anything during treatment. But having said that, but patient will have side effects. Every drug has its own side effects, right? So
Yes.
during the treatment,
Yes.
sometimes if you are irritating some particular structure, suppose we are hitting a oropharyngeal tumor, then in that case you are hitting the oropharynx. So oropharynx will have it'll have a mucositis. So that will be there,
Yes.
but that can be managed.
And even can we see the skin discoloration? So because most of the radiation after that, so we can see the discoloration
Yes.
in a traditional method. So in LUNAC, is there any skin changes after radiation?
Yes, skin changes will be there, but it will be lesser than what you see in a conventional machine because you are
Conventional.
able to see it every day. You can reduce a skin dose and then you can monitor it and you can keep it less than that. But at the same time, you cannot completely eliminate it because that's a process. This one, but patient will get back the skin color after 3 months.
Oh.
So, what are the patient experiences, Dr. Sai? Are they comfortable when they lie down for 20 minutes of
Mm.
time, and then when they come out, what do they share? Like, were they comfortable,
That's
or
the
they some claustrophobia? Have they experienced anything? Yes, especially pediatrics.
very nice question. It's a really a nice question. We also had the same feel that MRI means people get scared because it's a claustrophobic.
Yes.
But if you come and
Mhm.
see our MR LINAC, the other side of the MR LINAC is open. So only a small tunnel, and then you get to open both the sides. So whenever we treat a prostate or abdomen patient, the head is outside the tunnel. So people will feel that, okay, nothing is falling on my head, so I'm okay, I'm perfectly fine. So that way it is fine. The second thing is that like we treated almost till now, we have treated 600 patients and we treated a 6-year-old baby to 90-year-old man, but nobody has complained because what we do is that we do a counseling of the patient. What is a real advantage when you lie down? This is what we are doing. This is the image we get it. Because of this image, we are able to do like this. The moment patient understands that it's my advantage, they are taking time. They say that I'm happy to lie down for long. Please do the best for me. So that's a real advantage we had. And nobody has complained. And India, if you look at the noise also, we get more noise in the traffic signal than in the rooms, MRI room.
Yeah.
So we are all tuned to the noises.
Yes.
So that's not an issue at all.
Yes, yes. Yes, going forward, yeah, very, very great, learning point we are getting to understand. Yes, I think, yes, we do have nurses who are posted in the, in the setup. Yes, I think, yeah, a few little, more core fundamentals. What they should practice is taking the, obtaining the high risk consent, IV cannula with the 18 gauge and the NBM only as per treatment plan if the patient has, posted for with the contrast medium, right? And yes, going forward, now over to you, Lipika, and then we end the session.
So my questions will be what any kind of specific measures we need to carry forward for the patients and healthcare team members, any precautionary methods we need to follow, or is there any contraindications which may interact with this particular treatment?
Yes. I'll start with the contraindication. Contraindications are there in the sense like suppose some people are not MR compatible devices are there in their body. Suppose they have an implant which is not MR compatible, definitely not allowed. And if you have a pacemaker in your body, definitely we have to, unless otherwise it's a pacemaker is switched off or it is MR compatible, we are not allowed. So any metal objects in the body or any implant in the body which is not MRI compatible, then definitely not allowed inside at all. That's one thing.
Okay.
And coming to the precautions we should take is that like because it's an MRI machine, whatever the precautions we do, like in the sense like the staff, the nursing staff, the technologists should be trained for how to go into an MR room and what are the precautions you should do because MR has 4 zones, zone 1, zone 2, zone 3, zone 4. Zone 3 and zone 4 is the place where the nursing and the technologists are working. So those areas should not have any metal items and they should have the practice of going inside the room without carrying any kind of a non-metallic item, ferromagnetic items, which can really do a big accident. So we have to be extremely careful. Plus also all the crash cart, the oxygen cylinders, everything should be MRI compatible because we cannot afford to take any metallic cylinders. And you people know that a lot of incidents has happened and it can really catastrophic because it's 100 crore machine. So we cannot play with that.
Yeah. So yes, so we have come to the end of this session. Yes, and thank you, Dr. Sai. It was very wonderful, interesting topic. And within this 20 minutes of time, we cannot this is only the awareness. And I urge all the viewers to just refer our www.yashodahospitals.com for more health talks, reels, and webinar updates, and to experience the good patient's outcome. Until then, stay tuned. And I like to thank Sunita and Lipika and Sudha for your active participation for the same. And thank you, Dr. Sai.
Thank you so much. Great being here.
Thank
Bye-bye.
you.
Thank you.
Thanks.
Thank you.
Thank you.